exactly by 7.
Okay, we need to wait, huh?
We are streaming on.
Sir, 7:30 or exactly 7:30 start ಇದೆ.
Yeah.
Chinnu,
Sir, we are streaming
wait,
on
wait.
YouTube right now. Okay.
Okay, Chin. Close the doors. I hope I'm audible to all.
Yes, sir. Yes, sir.
Audible. Okay.
Sir, will you share
Sir, we are
slides?
streaming on YouTube. We will be live exactly by 8. Okay.
Pardon?
Sir, we are streaming on YouTube. We will be live exactly by 7:30, sir.
Okay, fine, fine. No problem.
Sir, there, doctor, your camera is not working. I guess it is blank, sir. Would request you to remove the shutter from the camera. Yeah, perfect, perfect. You are visible now.
Let's come.
Sir, will you share slides?
Yeah. Wait. Fine. Yeah, you can see them.
Yes, sir. Yes. Visible.
No. What is the time we are allowed? Half an hour?
No, sir. You can, sir. You can up to 1 hour. We can.
Huh? 1 hour worth of slides are not there, I think. I think mostly half.
No problem, sir. While finishing, after
No
finishing
problem.
we can close. After finishing the slides. No problem.
Okay.
Technical team, shall we start?
Yeah, we are live serving instruction.
Yeah.
Doctor, we would request you.
So can you make it a presentation now? I will give brief introduction about you, then we'll start, sir. Okay. Hello, I'm audible, sir?
Yes, audible, audible.
Okay. Yeah, good evening, everyone. I'm Tirupati Reddy on behalf of Glenmark Pharmaceuticals Limited. Welcome you all to today's webinar on the topic of optimizing hypertension management with triple combination therapy. It gives me immense pleasure to introduce our speaker for today's program, Dr. T. Naveen sir, Senior Consultant Cardiologist, International Cardiologist in City Neuro Hospital, Tirunelveli, Secunderabad. Now, without taking any more time, I request Dr. T. Naveen sir to initiate today's webinar. Over to you, doctor.
A very good evening.
Doctor, sorry to interrupt. Request you to please come in the center of the camera,
Pa-
please.
Pardon?
Request you to come in the center of the camera.
It's
Yeah,
fine.
perfect, sir. Yes, sir, perfect.
A very good evening to everybody. Are we good? Are we good?
Yes, sir, good
Yes,
to
sir.
go.
Yes, sir.
Are we good? Yes. Today,
Yes, sir.
today we shall be having a discussion on optimizing hypertension management with triple combination therapy. So the learning objectives for this session are to describe the burden of uncontrolled hypertension in Indian population, apply the current AHA ACC 2025 and the ESC 2024 treatment algorithms for clinical scenarios, identify patients who failed dual therapy and require escalation, justify the use of triple fixed dose combination therapy with ARB with CCB and thiazide, initiate, titrate and monitor telmisartan, amlodipine, hydrochlorothalidone combination in practice, counsel patients on adherence strategies for long-term blood pressure control. So the section 1 mainly deals with the global and Indian hypertension crisis, prevalence, control and cost. So less than half of the patient who have hypertensive receive treatment, nearly half remain undiagnosed. Only 1 in 5 achieve adequate BP control. And hypertension is a major driver of cardiovascular disease, stroke, and premature mortality. Hypertension is, in the truest sense of the word, a silent global crisis affecting almost 1 billion lives across the globe. So, as you can see here, so hypertension, as we can see, the epidemiology of hypertension, it has almost 300 million people live with hypertension. It has a 12% mortality rate, and the increase in India, that is the Asia Pacific region, is quite high. From 1990 to 2019, if we see, in Europe and Americas, there was only a 40% increase, but in the same duration of time, there is a 144% increase in the Asia Pacific region, which includes India, which highlights the impact of rapid urbanization, lifestyle transitions, and population and aging. So now the early onset of major cardiovascular risk factors driving premature diseases is shown in the Interheart study. And then in the studies, 12 key cardiovascular risk predictors in Indian cohort were studied in pure study. And high population attributable contribution of hypertension, raised non-HDL cholesterol, diabetes, abdominal obesity, low education levels, indoor air pollution, and tobacco use have been associated. Now moving to the pathophysiology of hypertension. In hypertensive patients, there is RAS overactivation, in which there is an increased angiotensin 2 release, which causes vasoconstriction, aldosterone release, and sodium retention. There is sympathetic overdrive, which leads to increased heart rate, cardiac output, and peripheral vascular resistance. There is increased vascular stiffness, which leads to endothelial dysfunction, reduced nitric oxide availability, and increased atrial rigidity. And there is volume excess with impaired renal sodium handling, fluid retention, and raised preload. All this lead to target organ damage like LVH, left ventricular hypertrophy, coronary artery disease, CVA, stroke, and CKD with proteinuria. So now cardiovascular risk assessment, the most popular risk assessment tools are the ASCVD 10-year risk course and the prevent calculator. And in general adults, what are the BP targets? Is our BP target in general adults is less than 130 by 80. In diabetes also, it's less than 130 by 80. And then in age greater than 65, the ambulatory patients, if they are ambulatory, it's less than 130 by 80. Although in the sprint trial, actually their target was relatively lower than 130/80. But like it's better to err on the safer side and not go very aggressive in management, or some patients they might suffer, elderly patients they might suffer falls who are greater than 85. In pregnancy, the BP target is less than 140/90. This is according to the ACOG guidelines. Now section 2. So the AHA to 2025, the ESC 2024 target and defining dual hypertensive therapy failure. So first of such 2024 stepwise approach for management of hypertension is a DASH diet. Sodium reduction less than 2 grams per day. Aerobic exercise greater than 150 minutes per week. And for such patients in the step 1, we give monotherapy. In selected patients like low risk hypertension, high normal BP and very high cardiovascular risk. So we start off monotherapy in such cases. Otherwise, we give lifestyle modification and monotherapy. So, and step 2 is dual fixed dose. If so, first is if with step 1 lifestyle modification and monotherapy in the treatment groups that we have just described, even then if the BP is not controlled, then we go for dual fixed dose combination. The most prescribed ones are the ARB with CCB combination or the ARB with thiazide combination. Fixed dose combinations are preferred for adherence advantage. And then even with this, if the BP is not controlled, our next step is like to go for triple therapy or resistant hypertension workup. So the preferred agents for triple therapy are ARB with CCB and thiazides. Now, if the patient has resistant hypertension, then we have to add some a mineralocorticoid antagonist as spironolactone. And then the fourth agent that we have to add after aldactone, like spironolactone, is a beta blocker. And in beta blocker also, although it's not mentioned here in the in the AHA resistant hypertension guidelines, a vasodilating beta blocker like carvedilol is more preferred. So in general strategy, so this is a crowded slide, but to break it down, it is essentially what we have discussed in the previous slide itself. So step 1 is like we try lifestyle modification and monotherapy. With that also, if BP, if it's not in range, we start a combination of ASARB with either a CCB or a thiazide diuretic. And with that, up to 60% of the people are controlled. And with the starting dose itself, like if we increase to full dose, almost 90% of the people are controlled. So true resistant hypertension occurs in up to 5% of the patients. And when you have true resistant hypertension, the actually the algorithm asks to refer to a hypertension specialist. So what we do is first secondary causes of hypertension we have to rule out. So like something like obstructive sleep apnea, aldosterone renin ratio, urine fermetanephrines, and to rule out pheochromocytoma. We have to do all this. And then of course, as we have alluded to in the previous slides, we have to add after these medication, after the triple drug therapy, we have to add aldactone followed by a beta blocker. So again, going back to the same, initial monotherapy is preferred in the elevated BP if the BP is 120 by 70 to 139 by 89. So if the BP is elevated in this category, so initial monotherapy we give. So in moderate to severe frailty or symptomatic orthostatic hypotension, or if age greater than 85 also, rather than a double fixed dose combination, which better to start off with an initial monotherapy only. So to start off with, we start with a low dose double combination therapy with ACE-ARB or CCB, with ACE-ARB with a combination of either a CCB or a diuretic. So BP, we have to follow up the patient, and we have to assess it 1 month, each monthly if possible. So usually if BP is under control for 1 to 3 months, follow up for it, annual follow-up for recommended. So if BP is not under control with low dose double combination therapy, you can come to the next step, that is the low dose triple combination therapy. And then at any step, if there is a other indication for adding beta blocker like angina, MI, or a patient with heart failure, or in patients whom we need heart rate control, we can add a beta blocker to the low dose triple combination therapy. And then if BP is controlled after 1 to 3 months, every monthly we have to assess, and then we can follow those up patients annually. And then with this also, if the BP is not under control, we have to go to maximum tolerated triple combination therapy. And with this also, if it doesn't get under control, we have to evaluate the patient for resistant hypertension, following which we'll add aldactone and a beta blocker and a vasodilating beta blocker. Okay. And now coming to the rationale for combination therapy. So why in the like almost a decade ago, there was the guideline used to be to start with monotherapy first. But right now, except that niche of patients that we had discussed in previous slide, for most of the patients, they'll start off with a low dose combination therapy. So why do we start? What is the rationale for starting off with the low dose combination therapy? Is that it leads to greater reduction in blood pressure compared to monotherapy. There is reduced adverse effects via complementary mechanisms. It blocks multiple pathophysiological pathways for hypertension. Better target organ protection is provided. It achieves faster blood pressure control and offers additional benefits beyond BP lowering, which is the anti-inflammatory, pleiotropic, and metabolic effects. So why triple therapy beyond dual therapy is a clinical necessity in hypertension? We can see low dose double therapy in only 60% of the patients, the adequate BP control is reached. 25 to 33% of the patients remain uncontrolled on dual combination therapy. And to bridge this gap, the triple therapy is the most logical next step to achieve BP targets. So, and what about the rationale for triple combination therapy? Large studies like SCOPE, INVEST all had accomplished. So, substantial portion of patients require three agents, that is almost 30 to 50%. Even in moderate uncomplicated hypertension, 30% of the patient might need triple therapy according to the STITCH trial. Triple therapy associated with higher BP goal achievement in more than 65% of the patients. Recommended in patients with high baseline BP 20 to 10 above the target risk or high cardiovascular risk. So, so the current recommendation is start treatment in most patients with two agents, not one. And triple therapy is favored in patients in whom the BP is very high at baseline, that is at least greater than 20 by 10 of HA or a high cardiovascular risk. So these are the trials. So these are some of the trials which look at a triple combination therapy versus double combination therapy, and there was a statistically significant lowering of BP with a combination of telmisartan, amlodipine, and hydrochlorothiazide compared to telmisartan and hydrochlorothiazide alone. And now coming to section 3, which is telmisartan, amlodipine, and hydrochlorothiazide mechanism, efficacy, and positioning. So triple therapy. Uh, just a second, I'll have to connect my laptop charger.
Hello, sir. Hello.
Team, technical team. Hello.
Yeah, tell me, sir. Yeah, can
Give
you
me
hear
one
me,
minute.
sir?
I will call the doctor.
Hello.
Yeah.
Yeah. Sorry about the interruption. The power outage in the area.
Okay, sir.
I'll just switch to my laptop. Wait. Slides are audible. Slides are visible.
Yes, sir. Yes, sir.
Yeah, so the triple therapy rational core. So the telmisartan blocks the AT1 receptor, which leads to decreased vasoconstriction, decreased aldosterone, and decreased sympathetic stimulation. And then the PPAR agonism gives to better insulin sensitization. The CCB, the amlodipine arm of it, blocks the L-type calcium channel, which causes arterial vasodilatation, decreased peripheral vascular resistance, and also it has a long T half, so we have better 24-hour BP coverage with no reflex tachycardia. And the hydrochlorothiazide part of it inhibits the renal sodium chloride co-transport inhibition, which leads to decreased plasma volume, decreased cardiac output, vasodilatation at low doses at 12.5 mg. And its natriuretic effects at such a low dose is better with minimal metabolic side effects, adverse effects. So hence we have the complementary mechanism of combining these three drugs is that CCBs, which causes increased arterial vasodilatation. So in some patients, they can develop pedal edema due to increased arterial vasodilatation. But then when you add an ARB to CCB, there's a balanced vasodilation in the both the afferent and efferent glomerulus. So there is decreased vasoconstriction, decreased aldosterone secretion, decreased catecholamine release, and then this edema, which potentially CCBs can cause, that is also further decreased by the adding diuretic and ARBs. So the additive synergistic action of all this leads to increased BP lowering efficacy. So the TAH components profile, looking at each individual drug by itself. So telmisartan has a T half of 24 hours, which is the longest ARB T half. So it needs only once daily dosing, no active metabolite needed, and it leads to better metabolic profile also with decreased insulin resistance. It is renoprotective and decreases albuminuria independent of its BP reduction. And telmisartan, according to the on-target trial, is non-inferior to ramipril in cardiovascular outcomes. So now the amlodipine, it has a very long half-life of almost 35 to 50 hours. It has, and then the onset of lowering BP is gradual. So there is no reflex tachycardia like it happens when we give non-sustained release of nifedipine. Sometimes we get reflex tachycardia. That does not occur in amlodipine. So it has coronary vasodilatation also, which has an anti-anginal benefit. And then it has been shown to decrease stroke also. And dosage related ankle edema, first of all, 5 mg minimizes the risk. And secondly, once we give it with telmisartan and hydrochlorothiazide, the synergistic action leads to reduce in the ankle edema also. Now coming to hydrochlorothiazide, at low doses, there is significant natriuresis without a significant hypokalemia, and it is more metabolically favorable without any adverse effects of thiazide diuretics at less than 12.5 mg. It synergizes with ARBs and counters the fluid retention that happens due to RAS. And it has, according to the ALLHAT trial, just like CCB, it has also proven cardiovascular outcome benefit at low dose. So there is, and patient adherence is also very much improved with 87.5% persistence improvement, 78.3% adherence improvement, and 33% goal BP achievement with the use of, when we use this as a fixed drug combination therapy, all the three drugs combined. So now about the global positioning of the fixed drug telmisartan, amlodipine, and hydrochlorothiazide combination. So the ESH guideline, they give it as step 3 post dual failure. In the ESC 2024, in the stage 2 itself, or an uncontrolled dual failure itself, the triple drug combination is advised. In the JNC one, it figures in the resistant hypertension protocol. In Indian guideline, it is the second line itself. And now the second section 4, the patient's journey from dual failure to triple drug combination therapy success. So case 1, the first case is a 55-year-old male with an uncontrolled hypertension on dual therapy. He's a diabetic, which is uncontrolled, which is HbA1c of 7.2%, and he's quite obese also, BMI 27.4, non-smoker. So the current therapy was a dual low dose fixed drug combination of telmisartan and amlodipine at 6 months. So the clinical BP was 165 by 102. It was which was an average of 3 readings taken. And the ABPM also confirmed a high elevated mean 24-hour BP of 162 by 99. So EGFR was fine, 68, and there was microalbuminuria with potassium within normal limit. So when you take out his ASCVD risk, he comes under the high 23% high risk criteria. So our target accordingly is less than 130 by 80. So his current BP is 165 by 102. So the gap to goal is how much? 35 by 22. So as we have alluded to in previous slides, when the gap to goal is high, like greater than 20 by 10 mm of Hg, then it's better to like start off with the triple drug combination therapy only. So now with system, before we escalate to systemic evaluation, first we have to sit down with the patients and confirm if he had been taking that double low dose double drug combination therapy firstly. So verify drug adherence, ensure that adequate doses of the first double dose therapy was taken. So tell me for certain 40 and amlong 5 mg, both are at optimal doses only. So we can consider up titration or escalation of these also. And then following which we have to like confirm the elevated hypertension through ambulatory BP monitoring. We have to advise him lifestyle assessment, that is reduce dietary sodium, and then ask him to cut down weight, like, and ask him to like exercise daily at least 40 minutes per, but at least 150 minutes per week exercise is necessary. Exclude any other secondary hypertension through ultrasound abdomen, aldosterone renal ratio you check, TSH if it's normal, or thyroid profile if it's normal, and exclude all the secondary causes. And then so the next therapy, after doing all this, we should escalate it. So where TSH fits in the guideline based positioning, as we have seen in the starting slides that we had seen. So step 1 was like lifestyle, and a certain niche of patients we give monotherapy itself, like age greater than 85, frail elderly patients. So for them we give monotherapy. So with that also, if it's not under control, then step 2 is low dose fixed drug combination therapy. And then we can either step up the low dose fixed drug combination therapy, or we can directly move to the step 3, which is like a triple fixed dose combination therapy. And then if with this also, if it is not under control, we have to start the protocol for resistant hypertension. We have to rule out secondary causes of hypertension, and then add aldactone, and then followed by a vasodilating beta blocker. So now suggested optimized management for this patient would be to, like, after as we had seen in the previous slide, after ruling out secondary resistant hypertension, after confirming adherence, like and then we can up titrate the dual dose combination also. And then with that also, if it's not under control, we can upgrade to the triple drug combination. Here one tablet just taken daily in the morning with or without food, that would suffice. And the rationale is like, basically we are going to be adding hydrochlorothiazide to the existing ARB with CCB backbone. And this is like, as we had discussed in the previous slide, like quite a guideline endorsed sequential logical step also. So, and then and it's simpler also. It's simpler than rather taking 2 tablets of a dual drug combination. Like just upgrading it to one triple drug combination improves adherence and reduces pill burden. So initiation and monitoring protocol, initiate the triple drug combination. So baseline will check the potassium, creatinine, uh, and ACR ratio, and then the glucose and lipids also. And then home BP monitoring twice daily at random time in the morning and evening. And 6 readings over 3 days before review we take. So the first review, we check the clinical BP and then his diary also. Why we do this? To rule out any white coat hypertension. And then we see if there's any increase in the creatinine. Up to 30% increase in creatinine, it's like acceptable when we start ARB. So, and then, and potassium level should be less than 5.5. We should assess for edema, dizziness, and adherence. So target assessment on month 3 will be to reduce BP less than 130 by 80, reduce ACR and expect it to decrease a little bit with ARB, like we have decreased like up to 30%. So we decrease is quite acceptable. That's fine, not a cause for concern. Now, if the BP even then if it's uncontrolled, then we can up titrate amlodipine, which as we had seen in the previous slide, amlodipine has the longest T half of this combination. Or we can add a fourth agent, like we can add a vasodilating beta blocker to the regimen. So long term management is like 6 monthly to annual review, and 6 monthly clinic review we have to do, and then annually we have to like target organ damage basically to the ECG and LVH regression on 2D echo, and then every visit we have to reinforce lifestyle with ongoing home blood pressure monitoring ongoing. So in this patient, the week 4 response triple drug combination therapy was initiated, and as we can see by week 4, BP dropped significantly to 142 by 88. Systolic BP reduced by 23, diastolic by 14. No adverse effects are there. So serum potassium was quite fine, and there was slight elevated elevation in creatinine, which is quite expected. Up to 30% is quite expected. That's not a cause for concern. Patient reports good tolerability, no ankle edema. Home BP monitoring diary showed consistent good readings, and then there was a good patient adherence also. So month 3, the BP had reduced to 128 by 79. And then this was sustained in the 24-hour ambulatory blood pressure monitoring also. And then the ACR also improved, and there was with a 38% reduction. So the HbA1c is stable. So there was no metabolic adverse effects with causing a increase in HbA1c. EGFR was stable at 66, and then there was no hypokalemia, no adverse events at 3 months. And now the long-term management plan to him would be every 3 months, we have to measure BP in the clinic. Home BP monitoring diary we have to review. Medication adherence reassessment should be done, and lifestyle continuous counseling of lifestyle reinforcement like salt restriction, weight loss, and exercise should be reinforced. Every 6 months, we should get a full metabolic panel, including HbA1c, lipids, renal functions, potassium, ACR assessment. And then annually, we have to assess ECG and 2D echo basically to assess for LVH regression. And then annually, we have to diabetic retinopathy also we have to rule out. Now, if we take BP both at the clinic and then we look at home BP monitoring diary to rule out white coat hypertension. If we still suspect white coat hypertension, we have to go repeat ambulatory blood pressure monitoring. And then ongoing lifestyle changes as we had discussed to him and we have discussed in the past previous slides, like DASH diet, salt restriction, exercise of aerobic exercise at least greater than 120 minutes per week, and a target BMI. In Indians, actually, it's better to keep a target BMI of less than 23, not 25. And then the waist circumference of less than 90 centimeter for Indian men. Now, patient communication and adherence strategies. So, all you can tell him that one tablets a day, all your BP medications in a single pill, we have to counsel that way. And then this has renoprotective action also. So take it every morning before if we, and one more way to improve adherence is if we link it to an ongoing habit, like daily morning people leave for work, and if we ingrain these pill taking this medication in his normal daily workday routine, the patient adherence improves. And then we have to keep motivating them to keep checking BP at home twice a week and bring the diary also, and we have to keep checking the diary also. So as we can see in this case, week 12 target BP was reduced, and then there was a minus 37 millimeters of mercury systolic BP and minus 23 millimeters of mercury diastolic BP reduction, and then the 40% reduction in the ACR. Now case 2, there is a 45-year-old male, and in this case he was newly diagnosed stage 2 hypertension with, he is also obese with a BMI of 30, non-smoker. He had a family history of premature cardiovascular disease with a father who had an MI at 52 years of age. His clinic BP was 168 by 106, and ABPM had confirmed the elevated BP. EGFR was 82, ACR was 38 mg per gram, showing microalbuminuria. LDL was also elevated at 148, non-diabetic, and secondary hypertension was also excluded. So if we use the ASCVD risk calculator, it comes to 18%, which is high risk category. So our target is less than 130 by 80. So and our gap is at least a 38 by 28, 26 millimeters of mercury gap to goal. So now the rationale, as we have discussed in the previous slide. So target, since the target is above the 20 by 10 millimeters of mercury, so it's but we have to immediately start dual or triple therapy initiation. And then as we can see, he's a high risk, high cardiovascular risk profile patient. So early and intensive BP control is essential. And then microalbuminuria signals target organ damage. So target organ damage has already occurred. So we have to rapidly normalize his BP. So, and as we can see, as we had discussed, triple drug therapy also confers renoprotection via the ARB component. So, as we can see, this is stage 2 hypertension. So, we have to start with a combination therapy only, not a monotherapy. And then the decision had been taken to initiate triple therapy as first line triple therapy, since the target was so high. So we can see in by the end of first month, we had achieved a BP reduction to 146 by 90. Month 3, we had achieved 126 by 78 millimeters of mercury reduction. So systolic BP reduced by 42, diastolic by 28 at 3 months, and goal of less than 130 by 80 was achieved by 3 months. So ACR also improved, microalbuminuria decreased because of the early protection, renoprotection with telmisartan. Serum potassium was stable, it had not elevated. EGFR was also stable. No ankle edema, then there was excellent tolerability. Now LDL still remained high, so statin was added, and home BP monitoring diary showed very good BP control and with very good adherence with a single pill fixed dose combination strategy. So key clinical results lessons from early triple therapy in a 45-year-old chap was that early intensification prevents target organ damage progression. As we had seen, microalbuminuria reduced significantly within 3 months. So this reflects early nephroprotective effect of ARB-based triple fixed drug combination therapy. And then stage 2 hypertension, which with such high risk in which target organ damage has already set in. So both the AHA and ESC guidelines support bypassing the sequential dual and then triple escalation when our target BP is greater than 20 by 10 mm of Hg. So direct triple therapy is also guideline endorsed that way. So and then single fixed dose combination therapy improves adherence in such young working age patients. And as we have discussed, we can do lifestyle like we can link a single pill taking with a habit also, like we can link it to his daily routine. Like we can ask him, before you start work daily, you have one tablet daily in the morning after or before breakfast, and you can go to work, you can ask for it. And now the section 5, the clinical trial subgroup data and safety profile of TIH. So as we can see, the TIH YTI trial, it was done to assess the safety profile of the triple drug regimen. And then it was basically, so this was just to like assess the safety, how safe the triple drug combination therapy is. And the result was that it received, according to the trial, TH achieved significantly greater systolic BP reduction versus double drug combination therapy, and showed superior diastolic reduction when you compare it to just telmisartan and amlodipine. And additionally, triple drug therapy consistently achieved higher BP control rates versus double drug across all subgroups, even when patients with diabetes and CKD. Superior efficacy was observed both at early week and it was sustained by week 8 also. So TAH demonstrates more effective and consistent BP goal attainment compared to double drug therapy. Now phase 3 clinical trial study overview. So in this, the aim was to investigate the efficacy and safety of combination for patients with an inadequate response to 80 milligram of telmisartan and 5 milligram amlodipine therapy. And then the phase 3 clinical trials also showed that diastolic BP reduction was more with triple drug combination therapy. And then systolic BP also was reduction was more. And this reduction was statistically significant. So additionally, it was shown that in these trials, triple combination therapy consistently delivers superior BP control across all endpoints versus dual therapy. And then it achieved higher control and response rates. It demonstrates greater efficacy in both absolute BP reduction and target achievement. This supports the need for early intensification beyond dual therapy to overcome residual uncontrolled hypertension. And it had showed consistent, robust clinical meaningful benefits across all the subgroups, regardless of patient had diabetes or regardless of patient had any kidney disease. Now coming to evidence from India in Indian patients. So here, as we can see, this study was done to assess the efficacy and safety of triple versus dual combination therapy in essential hypertension. So as we can see, both diastolic and systolic BP had shown superior reduction in even in Indian patients in triple therapy when compared to just double therapy with. And this time around, this comparison in this study was with a telmisartan and hydrochlorothiazide combination. And then this study was for efficacy and safety of drug combination to assess the efficacy and safety in uncontrolled hypertension. And in this also, in this study also, as we can see, as like in the previous trials, triple drug combination therapy achieved significant BP reduction at 120 days with 100% of the patients reaching target BP. And now the take home pulse. So just condensing all that we had learned in this session together. So basically, once we diagnose BP, if it's a stage 2 BP greater than 140 by 90, confirm the BP with either rule out white coat hypertension, confirm it with either home BP monitoring or ambulatory blood pressure monitoring, assess the ASCVD. ASCVD is the most widely used risk calculator. We have to assess it, and then we have to rule out target organ damage also, like basically retinopathy, nephropathy, and then any LVH through ECG and 2D echo we have to do. And then if our treatment goal is greater than 20 by 10 mm of Hg, we can directly move on to a triple drug combination, or we can start with a dual drug combination therapy and then keep reviewing the patient every month. So if there is dual drug failure, we can move on to either escalate increasing the dose of the dual drug therapy, or better yet, we can directly move on to a triple drug therapy. Monitor by week 4 the potassium and creatinine, and then if the goal is achieved, we can do annual checkup of the patient with annual review of target organ damage of through regular ECG 2D echo monitoring. And then with the triple drug therapy also, if there is no control in BP, we have to rule out secondary hypertension, and then we have to add a fourth agent, which is spironolactone. And then if that all spironolactone also doesn't work, we have to add a vasodilating beta blocker. Throughout all this flow chart, if the patient has any other indication for beta blocker, like a heart failure patient, or in patients in whom we have to reduce heart rate, or if it's a post MI patient, then we have to add a beta blocker. So now 5 clinical pulses. Early escalation to triple therapy is essential in patient uncontrolled on dual therapy, especially when BP is greater than 20 by 10 mm of Hg. ASARB with thiazide combination targets have complementary mechanisms leading to greater and faster BP reduction. Triple drug combination therapy improve adherence and persistence, translating to better long-term BP control. Addition of low-dose thiazide enhances efficacy without significant adverse metabolic effects. Effective BP control with triple therapy contributes to improved target organ protection, including renal and cardiovascular benefits. So, anybody wants to take these questions? Right,
So just give me 1 second, I will check.
right. So I would also like to hear from our fellow doctors, like in your clinical practice, according to your experience, what proportion of hypertension do you feel are truly at goal? How often is triple therapy initiated?
Sir, actually, they are unable to open their mic, sir.
Oh, okay, okay.
Only it's one-way communication from our end.
Oh, okay, okay, fine.
Just they
Okay,
are attending.
right,
Yeah.
right. So if there's
Just give me
nothing
one
else, I
second, sir. I
know.
will check.
Yeah, 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 sure.
So there is one question. Like triple drug nowadays, many other like chlorothalidone or metoprolol combinations are there. How this telmisartan amlopipine hydrochlorothiazide is different to those?
So one way the hydrochlorothiazide is different from a chlorothalidone is one biggest advantage it has is especially in elderly, chlorothalidone can lead to increased incidences of hyponatremia. So that incidence of hyponatremia is lesser with hydrochlorothiazide. So that way, this combination fares better when compared to a chlorothalidone based regimen.
Okay. Thank you, sir. Thank you. Yeah, no more questions, sir. I will conclude. Just 1 second, sir.
Right, sir. If there are no other questions, with your permission, I'll close the session.
Yes, sir. I will give closing comments. Then we'll close, sir.
Sure, sure, sure.
Yeah, I would like to take a moment to thank you all for your active participation in today's scientific session. Your presence and engagement have made this event truly remarkable. Firstly, I would like to extend our heartfelt gratitude to Dr. Navin, sir. Your insightful presentation and the depth of your expertise have greatly enriched our understanding. Your contributions are invaluable, sir, and we are grateful for the time and effort you have invested in preparing and delivering such an informative session. I would also like to acknowledge and thank all our attendees for your active participation. Thank you all once again for making this scientific session a success. Thank you very much, Dr. Navin, sir.
Right, sure.
Yeah. Technical team, please
You're
conclude.
welcome, sir. Thank you.
Bye, sir. Good night. Technical team. Technical team, please conclude.
Hello, sir. Can I conclude the session? Hello.